Okay. First, want to thank Marcelo Soares for having invited me to this meeting. He probably invited me because I'm the organizer of the yearly keratoconus expert meeting. We talk on surgical visual revalidation techniques, and in this meeting, 40 or 50 of the top world experts are gathering together, trying to come forward with strategies that will be useful to less experienced surgeons. And so my talk is called Rings and More, because, and I was pleased to see some images of other techniques than just rings, implantation of ICLs or cachet intraocular lenses. So I hope I won't repeat what has been said by other surgeons before, but as you know, keratoconus cross-linking has changed a lot of things, but it's still a deceiving procedure because it only stabilizes the situation. And we have a lot of patients who want more, especially those patients who have stable keratoconus after cross-linking or because they are older, and specifically patients with contact lens intolerance. And they want to be functional again, and this is one of the reasons that in my strategy I always try to aim for near emmetropia. Of course, the expectations of the patients have to be realistic. They have to be aware that with contact lenses the visual quality will always be better than with any other surgical procedure. So I'm implanting artisan lenses since 1991. I have been involved through Theo Seiler very early with topography-guided surface ablations, and implanting Keraring specifically since 2010. What procedure are we going to choose to visually rehabilitate our patients? Well, the decision is based on parameters like spherical equivalent, astigmatism, corneal thickness, age of the patients, and so on. Don't forget, we always try to reach near emmetropia. So what are the advantages, disadvantages, and side effects of the different techniques? Topography-guided surface ablation always have to go together with cross-linking. The cross-linking has to be performed before or together with the ablation. It's a non-reversible technique. The tissue that has been ablated is not going to come back. The advantage is that the cone is recentered and that the cornea becomes more regular. Up to now, there were recommendations not to ablate more than 50 microns of tissue, but last Friday, during the last expert meeting, some surgeons came forward to change that parameter and would suggest us to ablate much more tissue in such a way that you always leave a minimum of 300 micron of stroma. If you keep, of course, the ablation to 50 micron, you can't take a lot of, you can't correct a lot of ametropia, and often the refractive error will be corrected incompletely. Phakic intraocular lenses, the question is whether you need cross-linking or not. You very probably need it in progressive keratoconus and in young patients. The advantage of that technique is that it is theoretically reversible. You can take away the lens. The disadvantage is that the cornea remains unchanged. You can correct higher myopias and higher astigmatism up to -7.5 diopter, and you have all the disadvantages of an intraocular technique, and what we fear the most is, of course, infections. Intracorneal ring segments, cross-linking possibly cannot be needed. Some surgeons claim that rings in themselves have a stabilizing effect on the conus, but in my politics I still, especially in younger patients and in documented progression, I still do cross-linking first. It's again a theoretically reversible technique. The conus is recentered, the cornea becomes more regular. We can as well correct higher myopias and astigmatism. And in the follow-up, what surprised me is that a lot of patients complained about halos, but these halos were not always disturbing. So let's look to some results. These are data from 2 years ago. Meanwhile, I have much more patients, but the data I have collected at that time included 19 eyes of patients where I performed topography-guided PRK. In 12 eyes, the cross-linking was combined with the ablation. These are some of the results we can obtain. In general, I apply that technique in moderate keratoconuses or first keratoconuses, and in this patient, the conus has been recentered and the astigmatism of the patient has been corrected, and the patient is satisfied. let's conclude. In my eyes, you have with this technique more side effects, possibly because the treated eye is more in competition with the better non-treated eye. I have slightly lower satisfaction rates than with other techniques, and the possibility of retreatment is limited because often we don't have enough tissue available. This explains this graph where the mean satisfaction is only at 65%, with some patients really disappointed. In intraocular lenses, I performed 14 implantations of phakic intraocular lenses in keratoconus patients, some artisan, some artiflex. We can treat with a quite high predictability the refractive error. Here in this case, the patient had a cross-linking first, which increased the astigmatism, and in the second stage, the patient had a phakic intraocular lens with a good uncorrected visual acuity. In this patient, we have an even higher myopia with some astigmatism, excellent visual results. Conclusion, the cornea remains untouched, but we have, on the contrary, a high predictability of our refractive outcomes, which results in a higher independence towards glasses or contact lenses. Surprisingly, patients nearly do not complain about side effects, possibly because they are used to see that badly, and we have higher satisfaction rates, which is again seen in this graph with 82.5% of satisfied patients. I have implanted 14 intracorneal rings in 13 patients. In 4 patients, I introduced 2 segments. I chose for Keraring because of its triangular shape, which gives us a more refractive effect, and because the triangular shape gives as well less reflections. You know that we have several models, several optical zones, several lengths, and so on. I have no experience with Ferrara rings and Intacs. Why did I choose for Keraring? Well, because I had an excellent service. You sent your data to Brazil, to Marcelo, with refraction topographies. They come back with a surgical plan. With the implants, you have to use the depth of the tunnels, the length of the tunnels, and to make these tunnels, I use a Zimmer LDV femtosecond laser that allows us to make the tunnels at a precise depth, precise position, precise length, and this should result in a higher predictability. Again, they give us an excellent advice. Once I've got a schedule from Keraring, they sent me back what data I should introduce into the laser. That makes things very easy. You need a special handpiece, which is the lamellar corneal surgery handpiece, which has an integrated top view camera, so you can see the applanated area. You have to mark the visual axis, of course. You can, the ablation, the handpiece in itself has a fixed focus of 500 micrometers, but you can vary the depth of the tunnels by sticking a foil of a different thickness on the window of the laser head, and this gives you the predictability in the depth of the tunnels. You can as well adjust the center of the trajectory manually by playing with these arrows. We have some excellent results, like in this patient where I was able to correct a high myopia and astigmatism. In some cases, we still have some residual astigmatism. As you may see, sometimes after implantation of rings, it takes some time before you obtain a stable result. This explains why in the beginning you had 4 diopters astigmatism, then later on 1.5, and even later on a 2.5 astigmatism. In some other patients, I had unpredictable results with no change in uncorrected visual acuity. And in one patient, I even had a worsening of the myopia. So the problem of rings in my hands, at least, I'm possibly not the most experienced surgeon. I have a problem of predictability of the refractive outcome. So conclusion, we recenter the cornea, we regularize the cornea, we have less near emetropia, we have halos, but not that disturbing, and satisfaction rates of approximately 66%. So with all of these techniques, we have encouraging results, as long as we have told the patient that their expectations should be realistic. Contact lenses give better results. I chose for topography-guided PRK in low spherical equivalent. The cross-linking is, of course, mandatory, and I use it as well in a second stage as fine-tuning tool. Phakic intraocular lenses are chosen in centered conuses with a good BCVA, and in higher myopia and astigmatism, and rings in decentered conuses with a slightly lower BCVA. Again, we can correct higher myopias and higher astigmatism. You can as well combine all these techniques, as the previous surgeon has showed us. So, phakic intraocular lenses in higher ametropias, topography-guided PRK for lower ametropias or for fine-tuning, and rings, especially when the conus is decentered, the BCVA is less good, but less predictable results. In fact, in our expert meeting, we can really see that you have two different schools, the ring school and the topography-guided PRK school. And on top of that, none of the experts are using phakic intraocular lenses. Ideally, both should have listened should listen to each other, or at least build up experience with both techniques. And when I asked to all of the surgeons present, only 4 or 5 of the 30 present combine all the 3 techniques. So possibly we have to learn a lot from each other, and we should be able to play with these techniques and hopefully come to better results later on. Thank you.
Thank you very much. And well, it's very late. You are really acknowledged to stay here for so long. And is there any question for any of the speakers that are still here? Dr. Vryghem will be happy. He has provided an excellent keynote to finish the meeting, because he has made a very comprehensive and didactic presentation, and I want to thank you for that. Any question, Dr. Vryghem or any of the speakers? Okay, so let me ask one question to Dr. Vryghem, just to close it. Are you happy with the outcomes? Because you were not here, but you listened to one of our presentations, and we have demonstrated that the rate of success of rings or segments is 50%. If we define success as gaining vision, decreasing aberrations, decreasing refraction, so we are not dealing with an optimal result. We have a long way, and for sure the future is very promising, but what we have at this moment is medium. It's better than nothing, but it's not as good as we think. We are encouraged because we're dealing with an untreatable disease in which we are getting good outcomes. But if you look at the outcomes in high volumes of series, they are not as good as we expect. So my question to you, are you happy with what you do?
Yes, I'm very happy, but I always tell that all the techniques we apply are called surgical visual revalidation procedures and not visual corrective procedures. And this has to be clear into the mind of the patients. On top of that, all these patients have tried a lot of things. They went through a long road, and often they are, if the result is not optimal in our eyes, they are quite satisfied. This you can see in the satisfaction rates. We have to be aware that we have no miracle solution for keratoconus, and even between experts, you have such different roads that we have to learn a lot of things about keratoconus still, and about the revalidation techniques.
Mm-hmm. Well, I think that the happiness for a cancer patient is not to die, but this is not happiness. We have, at this moment, a long way to improve our outcomes, and we are happy because we are improving some of our patients, but not more than 50%, and that means that we have a lot to learn in the way in which we have to really avoid corneal graft and to improve vision in keratoconus. So we have one question. Okay, the question is there any connection between keratoconus and allergy? The answer is yes, because ocular surface inflammation is one of the reasons of activation of the metalloprotease cascade, and Robin is the second. So patients with allergy, by the allergy itself, have an activation of metalloproteases, and this chronic inflammation in low degrees is one of the reasons of keratoconus. The second is this patient are rubbing the eye. So yes, there's a connection in 2 ways. Thank you. Any other question? Yeah, no more? Suggestions? Okay, as a summary, I could say that this symposium has been important. We know a lot of issues that are at this moment being addressed in keratoconus. We have rings, we have collagen cross-linking, we have the combination with excimer laser surgery, we have other methods, and others will be evolving. For sure, this is a starting point for a better life for keratoconus, and the next step is to study how to do it better, how to improve the quality of life. We need to measure the quality of life in these patients. Possibly we shall have the answer in many of our doubts at this moment about how to treat in those procedures that are much more improving the vision quality and the quality of life of our patients. So I want to thank Mediphacos for this opportunity to have this symposium, for this moderation, all the speakers and all the attendees for keeping us until so long. It is 8:30 and still we are here. Thank you very much, and the session is closed.